Welcome to the Home Health Quality Reporting Provider Training Webinar, Section GG, Functional Abilities and Goals. The audio for today's session is available by telephone or audio cast. To accommodate as many participants as possible, this program is designed for web audio. For the best webinar experience, we encourage participants to listen over their computer speakers. However, audio cast quality is subject to equipment, bandwidth, and internet traffic. If you experience unsatisfactory audio quality over your computer, please use the telephone dial-in option provided in your confirmation emails. Those listening over the telephone will notice a significant delay between audio and the slides on screen, and you may prefer to follow along with the slide handout. If you do not see the phone number in your webinar email, please send a message to the operator using the Ask Question button to the left of the presentation. You will receive a response by email. Assistance is available to those on the phone by pressing £0 on the phone. You may send questions or comments at any time using the Ask Question button on the left of the presentation screen. Then click Submit to send it. Individual responses to specific questions will be sent by email. Questions of general interest will be posted in the Q&A box, which can be viewed by everyone by clicking the Q&A button on the left of the presentation. A PDF of the slide presentation can be accessed by clicking the Materials button to the left of the presentation. Please note, due to revisions, the presentation displayed on the screen may not have the same page numbering as the handout. I will now turn the call over to Sharon Purcell. Please begin.
Good afternoon, everyone. Thank you for joining us today for the Introduction to Section GG, Functional Abilities and Goals webinar. My name is Sharon Purcell, and I will be your host and moderator today. Before I transition the presentation to Kathy and Charlotte, I will review a few housekeeping items. Due to the large number of participants on today's call, it was necessary to change our delivery platform. To ensure your audio is synchronized with the slides, we recommend using your PC to view and listen to today's presentation. If you experience audio problems on the PC and need to use the phone number and passcode provided, please download the presentation from the Materials button and follow along using the downloaded version of the presentation. This webinar is being recorded. It will later be posted to the CMS Home Health Quality Reporting Program web pages. We will provide you with details on accessing the recording via email when it is available. Closed captioning is available and will appear on the bottom of your screen. The audio can be controlled using the speaker icon on your computer taskbar in conjunction with the audio control on the webinar platform. The phone lines will be on mute for the duration of the presentation. Due to the large number of attendees on today's webinar, we are unable to field questions over the phone, but you are able to submit questions electronically. Click the Ask button on the left of the screen, type your message, and click Submit. Responses to technical questions can be accessed by clicking on the Q&A button. Responses to content-related questions will be addressed during future trainings. If you would like to download today's presentation slide deck, click the Materials button located on the left of your screen to access the shared files. Training materials can also be downloaded from the Download section of the Home Health Quality Reporting training page. The Download section is at the bottom of the training web page. Please note, this presentation is current at this time. However, Medicare policy changes frequently. We recommend that you check back on the Home Health Quality Reporting Program website periodically for updates. Throughout the presentation, there are specific references to links which might be helpful in getting up-to-date information. Today's presenters will be Kathy Roby and Charlotte Steninger. Kathy is a senior consultant for home health care at Qualidyne. She specializes in teaching and educating nurses, focusing on improving home health provider clinical outcomes and reducing acute care hospitalizations for home care patients. To achieve these goals, she conducts on-site audits of home health care agencies, analyzes workflow processes, and makes recommendations for efficient processes resulting in better outcomes for patients. Kathy is a frequent presenter on quality improvement topics and conferences across the country. Kathy holds a BS in Healthcare Administration from the Harvard Graduate Center, a Master's in Education from St. Joseph University, and a Bachelor's of Science of Nursing from the University of Connecticut. She is a certified home and hospice care executive and a certified trainer for integrated chronic care management. Charlotte is a consultant at Qualidyne and has over 18 years of professional experience in the home health care industry as a nurse case manager and clinical educator. Charlotte works directly with home health care agencies, assessing their compliance with state and federal regulations, and providing recommendations to improve clinical processes. She develops training and education on various topics relating to home health, best practices, and related regulation. Charlotte served as the Director of Staff Development at Interim Healthcare of Hartford for over 12 years, spearheading numerous initiatives, including staff education and efficient workflow operations. Charlotte's professional area of specialization is in promoting quality enhancement of healthcare systems using technology solutions. She has been a certified OASIS specialist clinical since 2006. Charlotte is a registered nurse and holds a Master's of Nurses in Nursing Education from the University of Hartford. She is also an active member of the Connecticut Association for Healthcare at Home Education. On slides 7 through 8 of the slide deck contains a reference list of acronyms that will be used throughout today's presentation. Today's webinar, Section GG, Functional Abilities and Functionalities and Abilities, information will provide home health providers with a high-level overview of changes to Section GG related to Home Health Quality Reporting Program. These changes to Section GG are scheduled to become effective on January 1st, 2019. Now that an introduction and housekeeping slides have been covered, I'm going to turn the presentation over to the presenters, Kathy Roby and Charlotte Steninger. Kathy and Charlotte, the floor is yours.
Thank you, Sharon, and thank you all for joining us this afternoon. The purpose of today's webinar offered by CMS is to prepare you to assist your organization and your staff in understanding the Home Health Section GG changes. The learning objectives are on your screen. After today's training, we would like you to be able to first describe the new assessment items in Section GG, functional abilities and goals. Second, to apply the coding instructions that we will go over today to accurately code practice scenarios. And third, to identify the resources that are available to you to guide utilization of the Outcome and Assessment Information Set D, OASIS-D. The overview of Section GG is what we will be covering today. This is going to go into effect on January 1st of 2019. Section GG is entitled Functional Abilities and Goals. The items themselves, GG 0100, prior functioning everyday activities. GG 0110 refers to prior device use. These elements will be assessed and documented at start of care, referred to as SOC, and resumption of care, referred to as ROC. The items GG 0130, self-care, and GG 0170, mobility, are assessed and documented at 4 time points: start of care, resumption of care, follow-up, and discharge from the agency, but not to an inpatient facility. Why is Section GG being added to the OASIS assessment tool? CMS is working to align quality measurement across post-acute care assessment instruments. This is part of completing our process to meet the provisions of improving the Medicare Post-Acute Care Transformation Act of 2014, commonly known as the IMPACT Act. The move towards standardizing assessment data elements facilitates 4 processes across settings: data collection, quality measurement, outcome comparison, and interoperable data exchange. That's quite a mouthful, but what we are really trying to say is that we need to be able to transfer data and interpret data across all settings. This graphic will give you perhaps a better, clearer understanding. As you can see on the left, we have a variety of different circles, each representing a different assessment tool used by a different post-acute care setting. Section GG being added to the OASIS tool to standardize and align with the other PAC settings is represented with the white section in the middle. So that now, with all these different colored settings, in the center we now have one area. These questions, these assessment items, will be common to all of us across inpatient rehabilitation facilities, IRFs, skilled nursing facilities, SNFs, and lastly, long-term care hospitals, LTACs. As you see on your screen, again, we are referencing a sample of GG0130, and you are looking at it across 4 different settings so that you can see that the elements are similar, from home health agencies in the back, the SNF in front of that, IRF in front of that, and LTAC at the very front. While they are not exactly identical, they are very similar, and the questions that are common to each are worded so that data that is collected is, as we said on the previous slide, can be exchanged and understood equally by all the different settings. I want to point out the difference between the Section GG and the M items that we are accustomed to. First, the items themselves, the elements, are different, and they are assessed differently. Item definitions for those in Section GG are not intended to be exactly the same as M items. As we go through, it will be very important for you to clearly identify and understand the inclusions and the exclusions, so that you will understand what is there and what is not there. You will also want to be very clear about the coding scales, so that when you review the practice scenarios and apply the items in Section GG, you will see that the coding scales are different and that you need to be very clear in your understanding of what each item means and how you would code it correctly. How will we use the data that we collect in Section GG? This information is going to be used to calculate the cross-setting quality process measure, percent of home health episodes with an admission and discharge functional assessment, and a care plan that addresses function. In other words, this will report the percentage of patients with a start or resumption of care and a discharge functional assessment and a treatment goal that addresses function. If we consider this slide and the information here in the context of the new conditions of participation, you can see how clearly relevant this is, that our care planning must clearly assess admission and discharge functional level, and that the care plan we develop must address those functional elements. That's bringing us now to taking a closer look at GG0100, the first of the items, prior functioning in everyday activities. So let's begin with that. The intent behind GG0100 is to identify the patient's usual ability with everyday activities. And remember, we are talking about prior to the current illness, exacerbation, or injury. It's appropriate that on the right-hand side of your screen you see a photograph, because I'm going to begin now to use a frame of reference that I use throughout this presentation. GG0100 is to give you the option to take a Polaroid of what the patient's usual ability in everyday activity is, so that you know what they could do prior to the current illness, exacerbation, or injury. On your screen, you now have a visual of what this item is going to look like when you are completing your OASIS. GG0100, prior functioning, everyday activities, indicate the patient's usual ability with everyday activities prior to the current illness, exacerbation, or injury. And we will be completing this only at start or resumption of care. GG0100A, this element is self-care. It is highlighted there on your screen and reads as code the patient's need for assistance with bathing, dressing, using the toilet, or eating, again, prior to the current illness, exacerbation, or injury. I want you to look carefully at how this is laid out. On the left, you have the coding elements, and we are going to look at these in more detail. And on the right, each of the functional ability elements that we will be assessing. GG0100B is indoor mobility, ambulation. Here, we are going to code the patient's need for assistance with walking from room to room with or without a device, such as a cane, crutch, or walker. I'm not going to repeat that same phrase each time because obviously we know that prior to current illness, exacerbation, or injury is present in each question. GG0100C is referring to stairs and asks us to code the patient's need for assistance with internal or external stairs, with or without a device such as cane, crutch, or walker. GG0100D is looking at functional cognition. Here we are going to assess and code the patient's need for assistance with planning regular tasks, such as shopping or remembering to take medications. When we go to assess and code the elements in this item, there are specific instructions for you to go about this process. Note on your slide, on the left it says, interview the patient or family. On the right, it references reviewing the patient's medical records, as these may well describe the patient's prior functioning with everyday activities. These are certainly two ways to go about gathering this information. However, we do always want to remember that while we can interview the patient or family, we can review the record, we always want to try to directly observe wherever possible. Here are your coding instructions. As I said earlier, we want to look carefully at these instructions so that when we assess the patient and we document their level of function, we are doing so accurately. You would code a patient 3 or independent if the patient completed the activities by himself or herself, with or without an assistive device, but with no assistance from a helper. Code it as number 2, needed some help, if the patient needed partial assistance from another person to complete the activity. Code 1, dependent, if the helper completed the activity for the patient. That is the critical word. The helper completed the activities for the patient. You would code this 8 or unknown if the patient's usual ability prior to the current illness, exacerbation, or injury is unknown, despite observation, interview of patient and family, and a review of the medical record. You would code it as number 9, not applicable, if the activity was not applicable to this patient prior to the current illness, exacerbation, or injury. Note, a dash is a valid response for this item. However, given the specific coding options you've been given, CMS reasonably expects the dash use to be a rare occurrence. Here's a tip. If no information about the patient's ability is available after attempts to interview the patient or family and after reviewing the patient's clinical record, you would code this as 8, unknown. Let's move on now to GG0110, prior device use. The intent behind this is to identify the patient's use of devices and aids immediately prior to the current illness, exacerbation, or injury so that we can better align our treatment goals. This is what the element will look like on your screen or on your paper tool when you are doing your OASIS assessment. GG0110, prior device use. In the element, you can see it says check all that apply, and it provides you with a list of possible options for aids or devices that the patient might have been using. Again, in doing your assessment, your options are to interview the patient or family and to review the patient's medical records describing the patient's use of prior devices and aids. But you also want to directly observe how the patient completes the task. The coding instructions for this element are asked first to check all devices that may apply. You are not being asked to select one, but it says clearly check all devices that apply. The next alternative is to check Z, none of the above, if the patient did not use any of those listed devices or aids immediately prior to their current illness, exacerbation, or injury. A dash is a valid response for this item. CMS does expect a dash use to be a rare occurrence. DG0110C refers to a mechanical lift. This is any device that a patient or caregiver requires for lifting or supporting the patient's body weight. Examples include, but are not limited to, the stair lift, which is pictured on your slide to the right, a Hoyer lift, or a bathtub lift. This is a small list. There may be others. But remember the definition. A device a patient or caregiver requires for lifting or supporting the patient's body weight. GG0110D refers to walkers and says include all walker types, Examples include, but are not limited to, a pickup walker, a hemi walker, rolling walker, or platform walker. Although they have a traditional walker shown on the slide, remember, there are a great many different varieties and options, and you want to include all walker types in your consideration when you answer this question. GG0130, self-care, and GG0170, mobility, are where we will turn next. The intent behind these two queries is to identify the patient's ability to perform the listed self-care activities and the discharge goal. GG0170 identifies the patient, their ability to perform these listed mobility activities and the discharge goal. You can see them on the slide. When do we do these two elements? GG0130 and GG0170 are completed at start of care and resumption of care to assess the patient's performance at sock and rock. They are assessed at follow-up to identify the patient's performance at that time point. And lastly, they are done at discharge from the agency, not to an inpatient facility. And this is to identify and document the patient's discharge performance. And how will we do that? How will we complete this performance assessment? The specific instructions say that we are to, licensed clinicians may assess the patient's performance based upon direct observation, which is the preferred modality. However, this may include reports from interviewing the patient, conferences with other clinicians, care staff, and/or family members. Whenever possible, CMS invites you to use a multidisciplinary approach to patient assessment. This is, again, bringing together these changes and the new conditions of participation that we have been working with since January of this year, where we have begun the process of using an interdisciplinary team, an interdisciplinary approach, where we are getting information and completing our observation with reports and information from other parts of the care team. Patients should always be allowed to perform activities as independently as possible, as long as they are safe when you are observing them as part of your assessment. If helper assistance is required because the patient's performance is unsafe or of poor quality, you must score their functional level according to the amount of assistance provided to them. Activities may be completed with or without an assistive device. The use of the device to complete an activity should not affect the coding of the activity. Remember, we are scoring according to the amount of helper assistance that is provided, not whether or not a device was required. Patients with cognitive impairments or limitations may need physical and/or verbal assistance to complete an activity. Again, code your response based on the patient's need for assistance to perform the activity safely. We do not ever put the patient at risk to perform the assessment. You want to be aware of the potential for choking risk due to the rate of eating, the amount of food placed into the mouth, and also the potential for the risk of falling. On your screen, you have now what this element looks like when you go to complete your assessment documentation. GG0130. On the left, highlighted in yellow, you can see that we have here sock rock performance. And as it says, you're going to enter the code for the amount of assistance required in that box. Each of the elements you'll be assessing is on the right. You can see here that this does extend on, and there are many items that you will be looking at as we go through this process. This is an extensive assessment, and we will be documenting the patient's performance level at start and resumption of care in the far left column for each and every one of these different mobility activities. Let's take a look at some specific instructions as we gather data on this performance assessment. The patient's functional status should be based on a functional assessment that occurs soon after the patient's start or resumption of care. It should reflect the patient's start or resumption of care baseline status and be based on direct observation of activities to the extent that is possible. When possible, this assessment should occur prior to the start of therapy services so that you are capturing the patient's true baseline status. Therapy interventions that occur in the start of therapy services may affect the patient's functional status, and if they are included, if your assessment is done after that start of therapy services, you will not have a true baseline assessment. Remember my analogy of the Polaroid picture? This is where you are right now. You are doing your start or resumption of care performance assessment. You are taking a Polaroid picture of where this patient's baseline is and then documenting that picture in each of the elements in this particular item. A patient's functional ability can be impacted by the environment or the situation that the clinician encounters in the home. Observing the patient in different locations and circumstances within the home is important in order for you to have a comprehensive understanding of the patient's functional status. That's the reason why some of these assessments might be done in the kitchen, in the living room, in the bedroom, or in the bathroom. Because in order for you to truly assess each of the different functional abilities, you're going to need to do that in the specific locations that are appropriate. If the patient's status varies during the assessment time frame, you want to record his or her usual ability to perform each activity. Do not record the patient's best and worst performance. Instead, record the usual performance, because your Polaroid picture needs to give you a full and clear picture of what this person's usual ability to function is. I want to call your attention here to one of the statements that we've just made. If the patient's status varies during the assessment time frame, this has been highlighted in blue, and the blue bubble reminds us that we have a maximum number of days within which to complete the comprehensive assessment. Your initial start of care assessment must be completed within the 5 days from start of care, and your resumption of care needs to be completed promptly after the patient returns to the home setting. The yellow bubble is reminding us that a patient's usual performance is his or her ability greater than 50% of the assessment time frame. Remember, we do not record the best and the worst performance. We are looking for the usual performance greater than 50% of the assessment time frame. GG GG0130 asks us to project a discharge goal. You can see what the element looks like on your screen. The number 2 column, highlighted in yellow, says discharge goal and has code boxes for each of the elements that you're going to be assessing. So that as you identified in column 1, their current start of care and resumption of care performance, you are now going to be asked at start and resumption of care to identify the discharge goal for this patient. You're going to see here on this screen the full range of all the elements that you will be looking at as you complete this process. Here we have some specific instructions for establishing the start or resumption of care discharge goal. You're going to code or establish the discharge goal for each of the activities using a 6-point scale or one of 4 activity not attempted codes. Use a dash for any self-care or mobility goals that were not coded. There are very specific instructions. Discharge goals may be coded the same as your start or resumption of care performance. They may be higher than the start or resumption of care performance, or possibly lower. If the start or resumption of care performance was coded using one of the activity not attempted codes, and we will go through the definition of each, a discharge goal may be submitted using the 6-point scale if you truly believe that this patient is expected to be able to perform the activity by the time you discharge them. Licensed clinicians establish a patient's discharge goal at the time of start and resumption of care based on several elements. These include the patient's prior medical condition, the start of care and resumption of care assessments, self-care and mobility status, discussions with the patient and family, your professional judgment, your profession's practice standards, the treatments that are anticipated to be provided, the patient's motivation to improve, the length of stay on your service, and the actual discharge plan. But goals should be established as part of the patient's care plan. And again, I bring you back to the conditions of participation, where we are developing a care plan with the patient so that the patient is motivated to participate and improve, and that this should address where they feel that they are going to be. GG0130, follow-up performance. We have been talking about establishing an assessment and a goal at start and resumption of care. Now let's take a look at number 4, follow-up performance. We are only completing these 3 activities on a follow-up assessment. It's important that you note that the specific activity assessments that are collected and coded within GG0130 differ for the various data collection time points when we complete an OASIS assessment. These are the items that we would be collecting on a follow-up assessment. And you can see them all listed here on your screen. GG0170, follow-up performance, so that you have all of these here for mobility. Let's take a look now at what follow-up performance, how we would go about assessing this. The instructions tell us that we should code the patient's functional status based on an assessment that occurs within the required assessment time frame, so that as a clinician, you conduct a follow-up performance assessment at the specific time frame for doing a follow-up OASIS tool. Let's take a look now at GG0130, discharge performance. You are going to be completing these specific assessment of these activities only at discharge, and they are listed out in this snapshot of the item itself, as you would see it. You can see that there are a number of elements that are actually going to be assessed, and they are identified to be included in a discharge assessment. The discharge time period under consideration includes the last 5 days of care. So once again, you are taking that snapshot of your patient. Sometime you're considering all of the last 5 days of care, the discharge visit itself, plus the 4 preceding calendar days. You're going to look at what the patient could do and code their functional status based on your assessment that includes or is close to that time of discharge, the actual discharge visit and the 4 preceding calendar days. The purple box is reminding you that the discharge time period is specific for the type of assessment you are doing. For most OASIS items, it is the day of assessment. But remember, we have said that the discharge time period is the last 5 days of care. The item wording or the related guidance will always specify the time period under consideration for you, such as, in some instances, it might be since the most recent start or resumption of care. We talked about there being a 6-point scale for coding these items, and we are going to go through these carefully so that we are all clear in understanding how to apply them. Code 6 is independent. 5, setup or cleanup assistance. Code 4 involves supervision or touching assistance. Code 3 is partial or moderate assistance. Code 2, substantial or maximal. And Code 1, dependent. So that you want to remember between Code 6, independent, and Code 1, dependent. We said that there were 4 activity not attempted codes. This gives us an excellent variety of options so that we can properly code exactly what has occurred during your assessment. Code 7 says the patient refused. So the activity was not attempted because the patient refused. Code 9, this activity was not attempted because it is not applicable to this patient. Code 10, the activity was not attempted due to environmental limitations. One would certainly not ask a patient to walk outside in a snowstorm. Code 88 says this was not attempted due to medical conditions or safety concerns. If you recall on an earlier slide, we mentioned that we might not ask a patient to attempt a particular activity if they were at risk of falling or risk of choking. A dash is a valid response for this item, but given that we have 6 different codes for activity levels and 4 codes for activity not attempted, CMS expects the dash used to be a rare occurrence indeed. In order to better understand how to apply these codes, we're going to walk through an algorithm. An algorithm, I'm sure you're familiar, is a yes-no sequencing that enables you to make a very clear, optimal decision about which code you want to apply when you are coding GG0130 and GG0170. Let's begin by asking ourselves, does the patient complete the activity in question by him or herself with no assistance? Physical, verbal or nonverbal, cueing, setup, or cleanup? If the answer is yes, code this as 06 independent. If the answer is no, then you need to move on and ask yourself the next question. Does the patient need only setup or cleanup assistance from one helper? If the answer is yes, then we would code this as 05, setup or cleanup assistance. This means that the helper assists only prior to or following the activity, but not during the activity. For example, the patient requires assistance cutting up food, opening a container, or the setup of hygiene items or an assistive device, but not during the activity. If the answer to the question is no, then we must move on and ask the next question. Does the patient need only verbal or nonverbal cueing or touching, steadying, contact guard assistance from one helper? If the patient requires supervision or touching assistance, then we are coding their level of function as 04, supervision or touching. If the answer is no, then we would need to move on. Assistance may be provided at the 04 level throughout the activity or intermittently. Perhaps the patient requires verbal cueing, coaxing, reminding, general supervision for safety to complete the activity. Or the patient may only require some incidental help, such as a hand at the elbow or steadying assistance during the activity. This would be coded 04, supervision or touching assistance. If the patient needs active physical assistance, for example, lifting or trunk support from one helper, with the helper providing less than half or 50% of the effort, then here we would code this as 3, partial or moderate assistance, where the helper lifts, holds, or supports the trunk or the limbs, but is providing less than 50% of the effort. If the answer is no, then we need to move on through our algorithm to the next option. If the patient requires physical assistance, lifting or trunk support from one helper, with the helper providing greater than 50% of the effort, then in this case we are coding the level as 2, substantial or maximal assistance. If the answer is no, we're going to move on through the algorithm. And this brings us to a helper providing all of the effort, or the assistance of 2 or more helpers required to complete the activity safely. If the patient provides none of the physical effort to complete the activity, or the assistance of 2 or more helpers is required, then we must code this as 1, or dependent. This is going to bring us to the activity not attempted codes. I want to be sure that we are clear about how and when we would use these. Code 7 is patient refused. You would ask the patient to rise from the chair and walk the 10 feet across the room, and the patient says, no, I don't want to, I'm not in the mood, I don't want to go there, whatever, they refuse. So you would code this 07, patient refused. If the activity was not attempted and the patient did not perform this activity prior to the current illness, exacerbation, or injury, you would code this as 09, not applicable, because the patient did not perform this activity prior to this episode. Code 10 is not attempted due to environmental limitations. And we said earlier, an example might be that we cannot see how the patient walks outdoors because of the inclement weather. It might also be that the patient requires a tub seat to demonstrate a tub transfer and the equipment is not in the home. This is a new code, and its purpose here is to allow you to have a much clearer picture of why you have or have not done something. Code 88 says, we did not attempt this activity due to the patient's medical condition or because of significant safety concerns. Just some general tips. Do not use a dash if the reason the item was not assessed was because the patient refused, the item did not apply, there were environmental issues, or medical conditions or safety did not permit the activity. Those are the circumstances when you would code appropriately. A dash is used to indicate no information was available. Some additional coding tips include remembering the use of an assistive device and adaptive equipment to complete the activity should not affect the coding. If the only help the patient needs to complete an activity is for the helper to retrieve an assistive device, such as the reacher shown in the picture, or adaptive equipment, such as a cane for walking, a tub bench for bathing, then you would use Code 5, Set Up or Clean Up Assistance, as we discussed in the earlier examples. Here in the picture, you can see a very clear example of where two or more helpers were required to assist the patient to complete the activity. For the patient to transfer from that wheelchair into the car seat clearly requires two helpers, and this is a situation where you would code this as one or dependent because it did need two people for this to occur safely. I think it's time for a knowledge check. By now you must be getting a little tired of listening to me talking. What is your preferred method for assessing the patient's self-care or mobility performance? A patient self-report, family report, direct observation, report from other care staff. Think about these. If you're working in a group today listening to this program, discuss it with one another. Select an answer, write it down, no cheating now, and we're going to now click and see what the correct answer might be. And that would be C, direct observation. As I have said throughout the presentation so far, direct observation of what the patient is able to do is always the preferred way to go about this. A licensed clinician assesses the patient's performance based on direct observation and includes reports from the patient, clinicians, care staff, or family. Let's try another one. Which of the examples below best demonstrates allowing the patient to function, quote, as independently as possible, end quote? Feeding a patient who can feed himself in order to expedite mealtime. Allowing the patient to brush her teeth as much as possible, assisting only if she becomes fatigued. Providing the patient with a bedside commode when he's capable of walking to the bathroom with assistance. All of the above. Confer with everyone else. Think about that. Select an answer. Have you marked one off? Let's now see what the correct answer is. And the correct answer is allowing the patient to brush her teeth as much as possible, assisting only if he or she becomes fatigued. Allowing the person to brush their own teeth as much as possible encourages the patient's progress toward independence. It allows them to participate to the fullest extent possible. Patients should be allowed to perform activities as independently as possible as long as they can be safe. This is always our goal, to encourage independence and to bring that discharge goal to a higher level. Agency staff and families should allow independence wherever possible to promote quality of life and encourage a sense of well-being. One more. Mrs. W. uses a rolling walker. She cannot be considered independent for the Section GG walking items. True. Think about that. We talked about the use of devices. What do you think the correct answer might be? And the light bulb says that's false. Remember, assistive devices do not interfere with the coding of the activity. A use of an assistive device or adaptive equipment should not affect the coding of GG items. We're going to be looking at GG 0130 self-care, item-specific guidance and practice scenarios. And I'm sure that by now you've had quite enough of me. And so I'm going to turn this over to Charlotte, who's going to walk you through this section.
Thanks so much, Kathy. I hope you guys are enjoying this so far. I think we have a lot of great more information to share with you guys. We're going to start with GG 0130 self-care, the item-specific guidance and practice scenarios. One thing I want you to keep in mind is when we're going through the practice scenarios, we may include information for coding both the sock rock performance and the discharge goal, or you may just see information for the sock rock performance. Just keep that in mind as we're going through the practice scenarios. We're going to start with GG 0130A, eating. And eating is the ability to use suitable utensils to bring food and or liquid to the mouth and swallow food and or liquid once the meal is placed before the patient. So there are, a lot of things to think about when it comes to eating. Does your patient eat? Are they in PO? Let's think about a coding tip for that scenario. So if a patient uses a gastrostomy tube or maybe total parenteral nutrition, the assistance with the tube feeding, or TPN, is not considered when coding this item. If the patient does not eat or drink by mouth and relies solely on nutrition and liquids through a tube feed or TPN due to a recent onset medical condition, you're going to code this as 88, not attempted due to medical conditions or safety concerns. So that's really something to think about if they're using that type of nutrition. Moving on, if the patient does not eat or drink by mouth at the time of the assessment and did not eat or drink by mouth prior to the current illness, injury, or exacerbation, you're going to code GG 0130A as 09, not applicable. Now remember, there's a difference there from that scenario and the one we just mentioned. It all has to do with what they were doing prior. What were they able to do prior? You're going to see this type of coding tip throughout the rest of this presentation. If the patient eats and drinks by mouth and relies partially on obtaining nutrition and liquids via tube feed or TPN, you're going to code eating based on the amount of assistance the patient requires to eat and drink by mouth. Remember, with GG 0130A, we are looking at how the patient takes in food and drink orally. So as we're moving through this, I mentioned we're going to be doing some practice coding scenarios. Kathy is going to help me with some of those. So Kathy, introduce us to Mr. R.
Well, Mr. R is unable to eat or drink by mouth since he had a stroke 1 week ago. He receives nutrition and hydration through a G-tube, which is administered by a helper.
Okay, so when we're talking about coding GG 0130A, the sock rock performance, what do we think would be the best answer here? Is he at 01, dependent, 02, substantial maximal assistance, 09, not applicable, or 88, not attempted due to medical concerns or safety conditions? So let's think about this. Have you talked a bit about it with your friends yet? What do you think would be the best code for this scenario? Jot it down. Let's take a look at the answer. And the best answer is code 88, not attempted due to medical conditions or safety concerns. With the rationale being, that Mr. R does not eat or drink by mouth at the time due to a recent onset medical condition, that stroke that he just had. And remember, again, this item includes eating and drinking by mouth only. Moving on, GG0130B, oral hygiene. Now, this is the ability to use suitable items to clean the teeth, dentures if applicable, the ability to remove and replace dentures from and to the mouth, and manage equipment for soaking and rinsing them. So when we're thinking about that, I want to go back to that snapshot that Kathy talked about. Maybe that was the patient you admitted last week. Were you able to identify what his oral hygiene was? Let's think of a coding tip to better inform that. If the patient does not perform oral hygiene during the home visit, determine the patient's ability based on the patient's performance of similar activities during the assessment or on patient and or caregiver report. Now, that's a great tip because a lot of times we may not see some of these activities actually performed in the home. Remember, though, direct observation is the preferred method of assessment. Let's look at another practice scenario. Kathy, can you tell us a little bit about Mr. S?
Mr. S has a helper. The helper provides steadying assistance to Mr. S as he walks to the bathroom. The helper applies toothpaste onto Mr. S's toothbrush. Mr. S then brushes his teeth at the sink in the bathroom without physical assistance or supervision. Once he is done brushing his teeth, washing his hands and face, the helper returns and provides steadying assistance as the patient walks back to his bed.
Okay, so now thinking about Mr. S, how would you code GG0130B, sock rock performance? Would it be 05, setup or cleanup assistance? 04, supervision or touching assistance, 03, partial moderate assistance, or 02, substantial maximal assistance. Okay, let's think about that scenario. What would be the best answer you think? Did it compare with your friends in the room? Let's jot it down. What would you think is the best answer? Okay, let's take a look at what that correct answer is. And it would be 05, setup or cleanup assistance. Remember, the helper provided setup assistance, putting the toothpaste on the toothbrush before Mr. S brushes his teeth. Remember, we're not going to consider the assistance provided to get to or from the bathroom to score the oral hygiene component. So moving on, let's take a look at GG0130C, toilet hygiene. Now, this is the ability to maintain perineal hygiene, adjust clothes before and after voiding, or having a bowel movement if managing an ostomy. Remember, we're including the wiping of the opening, but not the managing of equipment. And this goes back to something that Kathy said. Remember, in each of these items, what was included and what was excluded in the item. The focus for this component is on the clothing management and perianal hygiene. In addition to ostomy management, toilet hygiene is coded if the patient uses the toilet or a commode, is incontinent, or completes the bowel program in bed. Now let's take a look at GG0130E, shower, bathe self. This is the ability to bathe self, including washing, rinsing, and drying self, excluding washing of the back and hair washing or shampooing. Remember, we're also not including the transferring in and out of the tub or shower. See how this is really different than maybe some of those other similar items related to bathing and showering? It is indeed a different item. Think about that patient that you saw last week. How would you rate this item? Moving on, let's go to GG0130F, upper body dressing. This is the ability to dress and undress self above the waist, including fasteners if applicable. Is that patient able to undo their blouse, do their zipper, put on that bra if they usually wear it? Think about the things that they're able to do with that upper body dressing. Moving to lower body dressing, GG0130G, this is the ability to dress and undress below the waist, including fasteners, but it does not include footwear. That's really important because we're going to be capturing that in the next item. That item is GG0130H, putting on and taking off footwear. This is the ability to put on and take off socks and shoes and other footwear that is appropriate for safe mobility. Remember, we're including the safety in this, including fasteners if applicable. So when you look at the GG0130 items, it really all has to do with the tasks related to self-care. That's a really important distinction. And now we're going to move on to GG0170 mobility. And in this, we will be talking about the item-specific items and, again, some more practice scenarios. First, let's take a look at what that measure looks like. It's quite long. There's over 20 components to this measure. And we're going to review each of these items and on select items run through a few scenarios. Again, I'm going to remind you that as the scenarios come up, we may be including information to inform the sock rock performance and the discharge goal, or it may just focus on that sock rock performance. You will see both of those items, those areas highlighted on those slides. Let's start with GG0170A, roll left and right. This is the ability to roll from a lying on the back to left and right side and return to lying on the back of the bed. So it does include the patient moving back and forth in the bed. Let's look at a practice scenario to see how you would code GG0170A for Mr. R.
Roll left and right. At start of care, the physical therapist helps Mr. R turn onto his right side by instructing him to bend his left leg and roll to the right side. He then instructs him how to position his limbs to return to lying on his back, and then to repeat a similar process for rolling onto his left side and then returning to lying on his back. Mr. R completes the activity without physical assistance from a helper. Mr. R was moving about in bed without difficulty prior to hospitalization. The therapist expects that Mr. R will roll left and right by himself by discharge.
So, thinking about GG0170A, how would you code that sock rock performance for Mr. R? Would you code him as 05, setup or cleanup assistance, 04, supervision or touching, 09, not applicable, or 88, not attempted due to medical condition or safety concerns? Think about that scenario. How did Mr. R do with that? Take a few seconds, consult with your group, jot down your answer. Let's see what that correct answer is. The best answer is 04, supervision or touching assistance. Now remember, we talked about coding a discharge goal. What would you code your discharge goal to be for Mr. R? Would it be 06, independent, 05, setup or cleanup assistance, 07, patient refused, or 09, non-applicable? Again, take a few seconds, jot down your answer, and let's see what the correct code would be. The best response would be 06, independent. Thinking about GG0170A, at Sock Rock, the physical therapist provided verbal cues, instructions to Mr. R as he rolls from his back to his right side and returns lying on his back. But the physical therapist does not provide any physical assistance, and there's the key in understanding the coding. After the assessment and considering the current condition, the therapist expects Mr. R will be independent in rolling left and right at discharge. And again, that informs our discharge performance for this scenario. Let's look at GG0170B, sit to lying. This is the ability to move from sitting on the side of the bed to lying flat on the bed. Now, pretty simple measure here, but we are going to give you some more tips about what lying means in a few slides coming up. Let's move on to GG0170C, lying to sitting on the side of the bed. This looks familiar. I know it has. Most of you guys have been filling this out for a bit. So again, just to review, this is the ability to move from lying on the back to sitting on the side of the bed with feet flat on the floor with no back support. But I think, honestly, that we've had it for a while. It wouldn't be bad to review some coding tips. Let's take a look at one here. If the patient's feet do not reach the floor upon lying to sitting, the clinician will determine if the bed height adjustment, if applicable, or if a footstool is required to accommodate foot placement on the floor or footstool. Back support refers to an object or a person providing support of the patient's back. Another tip, if at the time of the assessment the patient is unable to lie flat due to a medical condition or restriction, but he could perform this activity prior to the current illness, exacerbation, or injury, you're going to code 88, not attempted due to medical condition or safety concern. Now, let's compare this to that next scenario. If at the time of this assessment the patient is unable to lie flat due to a medical condition or restriction and could not perform the activity prior to the current illness, exacerbation, or injury, you're going to code it as 09, not applicable. You see the difference? They weren't either in scenario be able to do it. However, it had to do what they were able to do prior to their current illness, exacerbation, or injury. Let's think about another coding tip, and this one is really good for GG0170A through C when we're talking about lying. Make sure you're using clinical judgment whenever you're trying to determine what is considered a lying position for a patient. A really good example of that is determining what is considered preferred for that patient, and it could be a slightly elevated resting position. And using that example, you can consider that lying for the patient. Let's look at GG0170D, sit to stand. This is the ability to come to a standing position from sitting in a chair, wheelchair, or on the side of the bed. Now, let's think about the assistance needed for that patient you're thinking about in that photograph. Do you have all the information for that? Maybe we need to think about how we're going to change up our assessment so we are gathering all that information. Remember, what is his usual performance? When we're looking at GG0170E, chair, bed-to-chair transfer, this is the ability to transfer to and from a bed to a chair or wheelchair. Now, this activity begins with the patient sitting and then moving or transferring to sitting in a chair, wheelchair, or at the edge of a bed. Let's consider a coding tip for this component. When sit to lying and lying to sitting are not assessed as part of GG0170E. If the patient does use a mechanical lift, for that assist to transfer from a chair to bed to chair transfer, and two helpers are needed for that assistance with that mechanical lift, you're going to want to code this as 01 dependent, even if the patient assists with any part of that chair, bed to chair transfer. The key component to that scenario has to do with the fact that we have two helpers assisting with that transfer. And in understanding that, let's look at another coding scenario for GG0170E.
We're looking at a chair, bed-to-chair transfer. The patient, Mr. L, had a stroke and uses a wheelchair for mobility. When Mr. L gets out of bed at start of care, the therapist moves the wheelchair into the correct position and locks the brakes so that Mr. L can transfer into the wheelchair safely. Mr. L transfers into the wheelchair by himself without the need for supervision or assistance during the transfer. The family reports that Mr. L does transfer safely without the need for supervision once the wheelchair is placed and locked. The nurse does not expect Mr. L's mobility status to change by discharge.
So let's look at how you would code GG0170E stock rock performance for Mr. L. Would you choose 05, setup or cleanup assistance, 04, supervision or touching assistance, 09, not applicable, or 88, not attempted due to medical condition or safety concern? Okay, think about your answer. Think about Mr. L. What do you think his ability really is? Jot down your answer. Let's take a look at what the correct answer would be. And that would be 05, setup or cleanup assistance. Now remember, we also provided information to inform a discharge goal for Mr. L. So what would you choose? Would it be 06, independent, 05, setup or cleanup assistance, 07, patient refused, or 09, not applicable? Think about your answer. Jot it down. Let's take a look. And the correct answer would be 05, setup or cleanup assistance. Let's think about why we chose those answers. And really it has to do with the helper. The helper must provide setup assistance only. Once setup is provided, Mr. L transfers safely and does not need supervision or physical assistance during the transfer. Now remember, the nurse expected that Mr. L will continue to need wheelchair setup assistance for this transfer at discharge, and that's how we got to the discharge goal of 05 for Mr. L. Okay, moving on. Let's look at GG0170F, toilet transfers. Now, this is the ability to get on and off a toilet or commode. Again, think about your patient. Do you have all the information you need to be able to code this measure? Let's think about it. We're talking about including getting on and off the toilet or commode, and that's what we're looking at. But let's look at a toilet transfer coding tip to help better inform us. Toilet hygiene and clothing management are not considered part of the toilet transfer activity. Moving on, let's look at GG0170G, car transfers. This is the ability to transfer in and out of a car or van on the passenger side. Do not include the ability to open, close doors, or fasten seat belts. Think about that. Again, in the measure it says what we're including and what we're excluding to code this item. Let's look at a car transfer coding tip. If the patient is not able to attempt car transfers, for example, because no car is available or there are weather or other environmental constraints, and the patient's usual status cannot be determined based on the patient caregiver report, enter code 10, not attempted due to environmental limitations. If, at the time of the assessment, the patient is unable to attempt car transfers and could not perform the car transfer prior to the current illness, exacerbation, or injury, you'll code 09, not applicable. Again, that's a good example of looking at what his prior ability was. So let's look at a coding scenario for car transfers.
The car transfer. On the day after being admitted to home health, Mrs. N works with an occupational therapist, an OT, on transfers in and out of the passenger side of a car. When reviewing the therapist's evaluation, the assessing clinician reads that when performing car transfers, Mrs. N required verbal reminders for safety and contact guarding assistance from the OT for guidance and direction. The therapist instructed the patient on strategic hand placement while Mrs. N transitioned to sitting into the car seat. Documentation showed that the therapist opened and closed the car door.
Okay, now thinking about Mrs. N in that scenario, how would you code GG0170G sock rock performance? Would it be 05, setup or cleanup assistance, 04, supervision or touching assistance, 03, partial moderate assistance, or 02, substantial maximal assistance? Take some seconds, think about your answer, and let's see what the best answer would be. And we're going to be looking at choosing code 04, supervision or touching assistance. Now let's think about the rationale behind that. The therapist provided touching assistance only as the patient transfers in the passenger seat of the car. The assistance with opening and closing the car door is really not included. Remember, we talked about that in the actual definition of that element. So you're not going to include that when coding this item. Okay, it looks like we might have a little bit of a technical difficulty pushing the slide, but we're going to go ahead and continue. GG0170I, walk 10 feet. So this is once in a standing position, the ability to walk at least 10 feet in a room, corridor, or similar space. We're going to start from standing position, and then remember, we're just going to have the patient walk at least 10 feet in a corridor or similar space. Now, moving on to GG0170J, walk 50 feet with 2 turns. So this element, we're going to be, again, once in a standing position, looking at that patient's ability to walk 50 feet and make 2 turns. Okay? So what does making 2 turns really mean? Let's think about that. So in this element, we are going to be asking the patient to walk 50 feet and then complete 2 turns. 2 turns are defined as 90-degree turns that can be in the same direction, 2 90-degree turns to the right, or 2 90-degree turns to the left. Or it can be in different directions, 1 90-degree turn to the right and then 1 90-degree turn to the left. Now, it's really important to remember that when you're assessing these turns, that you're not jeopardizing your patient's safety in their ability to perform this activity. Also remember that you can use an assistive device, for example, a walker or a crutch, for your patient without affecting the coding of this activity. So with that in mind, let's move on to GG0170J, a practice coding scenario for walking 50 feet with 2 turns.
Let's take a look at our patient, Mr. B. At start of care, Mr. B is recovering from a recent stroke and now has difficulty walking. Even with assistance, he is able to walk only 30 feet. Mr. B's care plan includes muscle strengthening and gait training. The therapist expects Mr. B will be able to walk 50 feet with 2 turns safely with the assistance of a caregiver for verbal cues and contact guard for steadying on the turns at discharge.
Okay, thanks, Kathy. So let's think about Mr. B in this scenario for GG0170J, sock rock performance. Would you code him at 02, substantial maximal assistance, 01, dependent, 09, not applicable, or 88, not attempted due to medical conditions or safety concerns? Take a few seconds, think about your answer, confer with your group if you got one there. What do you think is the best response? Let's take a look at the answer. And that would be 88, not attempted due to medical conditions or safety concerns. Now, we also gave you information to inform that discharge goal, so let's think about how would you code that discharge goal. Would it be 06, independent, 05, setup or cleanup assistance, 04, supervision or touching assistance, or 03, partial moderate assistance? Again, think about that scenario from Mr. B. What would you choose? Let's hope you chose 04, supervision or touching assistance. Now, why would we? Rationale being that Mr. B is ambulatory, but was not able to walk the entire distance because of his new medical condition, that stroke, right? So since the patient is unable to complete the activity at start of care, but was completing the activity prior to that recent stroke, code 88 it would be most appropriate. Although not able to complete the activity at start of care, the therapist anticipates Mr. B will be able to walk 50 feet with 2 turns safely with the assistance of a caregiver for verbal cues and contact guarding at discharge. Okay, now let's move on to GG0170K, walk 150 feet. So, once standing, this is the ability to walk at least 150 feet in a corridor or similar space. Remember, we're going to start from a standing position to code this measure. Let's look at a coding tip. If the patient's environment does not accommodate a walk of 150 feet without turns, but the patient demonstrates the ability to walk with or without assistance 150 feet with turns without jeopardizing the patient's safety, remember that's really important, you're going to go ahead and code using that 6-point scale. Looking at GG0170L, walking 10 feet on uneven surfaces. This is the ability to walk 10 feet on uneven or sloping surfaces, indoor or outdoor, such as turf or gravel. And again, once standing, we're going to assess that patient's ability to walk on an uneven surface. Let's look at a coding tip for this measure. If the patient is not able to attempt walking on uneven surfaces, for example, because there are no uneven surfaces, or there are weather or other environmental constraints limiting access, and the patient's usual status for walking 10 feet on uneven surfaces just cannot be determined based on the patient or caregiver report, you're going to use 10, not attempted due to environmental limitations. Keeping all that in mind, let's look at a practice scenario. And Kathy, introduce us to Mrs. N.
Mrs. N has severe joint degenerative disease. She's recovering from sepsis. When walking on the uneven driveway was attempted yesterday when Mrs. N came home from the hospital, she reports that her neighbor had to hold her belt and help lift her a little during a few steps. The neighbor also provided help to advance the walker across the gravel driveway as the patient walked.
Okay, so let's think about Mrs. N. How would you code GG0170L? The sock rock performance. Would it be 05, setup or cleanup assistance, 04, supervision or touching assistance, 03, partial moderate assistance, 02, substantial maximal assistance? Take a few seconds. What would be the best answer? 03. Understanding that per the patient report, Mrs. N required a helper to provide some weight-bearing support and assistance in advancing that walker as she walked 10 feet on uneven surfaces. The helper does less than half of the effort for the walking of the 10 feet on uneven surfaces. Looking at GG0170M, this is one-step curb. And this is the ability to go up and down a curb and or up and down one step. Now look at this. There's a bit of a skip pattern here I want to highlight here. If at the sock rock performance is coded at 07, 09, 10, or 88, you're going to skip to GG0170P, picking up an object. So this is really important to understand that if they're not able to do one step, we're not going to expect them to be able to do 4 steps or even 12 steps. Remember, the use of the assistive device and adaptive equipment, for instance, a railing or a cane, required to complete the activity should not affect the coding of that activity. So let's look at another coding scenario. This one is for Mrs. Z.
And with Mrs. Z, we are looking at her ability to go up one step or a curb. Mrs. Z had a stroke and needs to learn how to step up and down one step to enter and exit her home. At start of care, the physical therapist provided needed verbal cueing as Mrs. Z uses her quad cane to aid her balance in stepping up and back down one step. The therapist does not provide any physical assistance.
So how would you code GG0170M, sock rock performance? Would it be 04, supervision or touching assistance, 03, partial moderate assistance, 02, substantial maximal assistance, or 01, dependent? Think about it. Take a second to choose your answer. Now, let's take a look. 04 would be your best answer, supervision or touching assistance. Remember, the patient needed only verbal cueing to complete the activity of stepping up and down one step. Let's look on about GG0170N. It's a mouthful. 4 steps, right? So this is the ability to go up and down 4 steps with or without a rail. And again, that same skip pattern is identified there. So let's think about how would we answer that question for your patient, Mrs. J.
At start of care, Mr. J has lower body weakness, and the physical therapist provides light touching assistance when he ascends 4 steps. While descending 4 steps, the physical therapist faces the patient and descends the stairs, providing minimal trunk support with one hand on the patient's hip and the other holding the gait belt, as Mr. J holds the stair railing.
So how would you code GG0170N, Sock Rock Performance for Mr. J? Would it be 05, Setup or Cleanup Assistance, 04, Supervision or Touching Assistance, 03, Partial Moderate Assistance, 02, Substantial Maximal Assistance? Think about it. What would be your answer? Go ahead and jot it down, and let's see what the correct answer would be. And that would be 03, Partial Moderate Assistance. Remembering the therapist provided touching assistance as Mr. J ascends the 4 steps. The therapist provided minimal trunk support when he descended the 4 steps, providing less than half the effort to complete the activity. Therefore, the patient required partial moderate assistance to go up and down the 4 steps. Let's look at GG01700, 12 steps. This is the ability to go up and down 12 steps with or without a rail. Now think about that. How would you code that for that patient you're thinking of? Let's take a look at a coding tip. If at the time of the assessment the patient is unable to complete the activity due to a physician-prescribed restriction, for instance, no stair climbing for 2 weeks, but could perform this activity prior to the current illness, exacerbation, or injury, you're going to code 88, not attempted due to medical conditions or safety concerns. Looking at GG0170P, picking up an object, this is the ability to bend, stoop from a standing position to pick up small objects such as a spoon from the floor. Now, thinking about this, a good coding tip would be, if at the time of the assessment, the patient is unable to complete the activity, for instance, is unable to stand and could not stand, to perform this activity prior to the current illness, exacerbation, or injury, you would code this as 09, not applicable. Thinking about this, let's look at another coding scenario, this one from Mrs. C.
And here we're going to be looking at Mrs. C's ability to pick up an object. Ms. C has recently undergone a hip replacement. At start of care, she walks with a walker without assistance. When she drops a hairbrush from her walker basket, she asks her daughter to locate her long-handled reacher and bring it to her. Using the reacher, Ms. C is able to bend slightly and safely pick up the hairbrush with the reacher without need of additional assistance or verbal cues.
Okay, so how would you code GG0170P, Sock Rock Performance, for Ms. C? Are you going to code it as 05, Setup and Cleanup Assistance, 04, Supervision or Touching Assistance, 03, Partial Moderate Assistance, 02, Substantial Maximal Assistance? Think about the scenario, jot down your answer, and the best answer would be 05, Setup or Cleanup Assistance. And this is because the daughter provided setup assistance only by retrieving the reacher, and then the patient is able to use the device to pick up her hairbrush safely. Now, let's take a look at the next couple of questions here. This is GG0170Q. Does the patient use a wheelchair and or scooter? So that's the question. But notice the 2 responses and the skip patterns associated with them. Okay? The skip pattern that is identified in this question really talks about the logic behind what happens if your patient doesn't use a wheelchair or scooter. Understanding that you wouldn't need to code any components related to the use of the wheelchair or scooter. This is a huge help, guys. I know this item looks big, but look at it. We're going to be able to skip some answers here if your patient doesn't use those devices. So remember that if a wheelchair or scooter is used, then we will proceed to detail the use of those specific devices in certain circumstances in the questions to follow. So when you're looking at, does the patient use a wheelchair or a scooter, you're going to think about your clinical judgment, and you're going to determine if that patient's use of that wheelchair is for self-mobilization due to the patient's medical condition or safety. Now, if the patient is ambulatory and is not learning how to mobilize in a wheelchair and only uses that wheelchair for transport within a larger facility, like in an assisted living or an apartment complex, or even in the community, like for mobility outside the home, for instance, to a physician's appointment or to dialysis, Then you're going to code 0, no, for GG0170Q, does the patient use a wheelchair, scooter, and skip all the remaining wheelchair questions. So let's look at the next wheelchair question. It's GG0170R, wheel 50 feet with 2 turns. This item, once seated in a wheelchair or scooter, scores the ability to wheel at least 50 feet and make 2 turns. Again, there's that little topic about 2 turns. What does that mean again? Let's take a look. The turns are 90-degree turns and may be in the same direction, 2 turns to the right or 2 turns to the left, or in different directions, a 90-degree turn to the right and one 90-degree turn to the left. Remember that the 90-degree turns should occur at the patient's ability level and not jeopardize their safety. Let's look at GG0170RR1 and GG0170SS1. This indicates the type of wheelchair or scooter used. Notice they're basically the same question. The difference really is considering the type of device that is used may be based on the circumstance of wheeling 50 feet versus 150 feet. This distinction is important as CMS understands that with the increase in distance, the patient can fatigue and may require a change in the type of wheelchair or scooter used. Let's look at GG0170S, wheel 150 feet. In this item, you're going to have the patient seated in a wheelchair or scooter and assess the ability to wheel at least 150 feet in a corridor or similar space. A coding tip. If the patient's environment does not accommodate the wheelchair scooter use of 150 feet without turns, but the patient demonstrates the ability to mobilize the wheelchair scooter with or without assistance 150 feet with turns, not jeopardizing the patient's safety, then you're going to code using that 6-point scale. Let's look at GG0170S, a practice scenario for Mr. N.
We're going to be assessing the ability to wheel 150 feet. Mr. N uses a below-the-knee prosthetic limb. He has peripheral neuropathy and limited vision due to complications of diabetes. Via observation and patient report, the assessing clinician determines that Mr. N's usual performance is that a helper is needed to provide verbal cues for safety due to vision deficits, and the patient mobilizes his manual wheelchair a distance of 150 feet within his home.
Okay, so how would you code GG0170S, the start of care, resumption of care performance? Would it be 06, independent, 05, setup or cleanup assistance, 04, supervision or touching assistance, or 03, partial moderate assistance? So, thinking about your answer, jot it down. Let's look at what the best code would be. And that would be 04, supervision or touching assistance. Now, why would we think that? Remember, Mr. N requires the helper to provide verbal cues for his safety when using a wheelchair for 150 feet. There's really no physical assistance being provided in this scenario. It's all really just verbal cueing. So, that's a lot to think about if you think about that whole measure, GG0170. Did you have all the information you needed to code that patient when you were thinking about him? Let's see. Did you have all the information you needed for picking up an object? Did you have all the information you needed for a car transfer? Remember, GG assesses the need for assistance with self-care and mobility items. It was added to the OASIS-D for standardization and alignment with all PAC settings. Section GG items are different from M items, and we did review that a little bit. Remember that GG0130 and GG0170 use that 6-level rating scale and activity not attempted codes. This includes performance assessment and a discharge goal at start of care and resumption of care. So with all of that in mind, I'm going to turn this over to Kathy to give us a little bit of information regarding training and additional resources.
Thank you, Charlotte. I know that was a huge amount of material to go through and to try to cover and understand all the nuances of what we were going over. At this point in time, what we're going to briefly look at are some of the training and resources that are available to you so that you can use these slides and other resources to effectively train your staff. What you see here is an overview of what would be available to you on the Home Health Quality Reporting Program website. Starting in the lower left, there is a section there called Spotlight and Announcements. This is very important. Here is where you're going to see announcements of dates and times and registration announcements for programs that are forthcoming. The Home Health Quality Measure section will outline for you the quality measures that this data is being collected to support. The Home Health Star Rating section is going to review for you all the components of the star rating system and why it's important. In OASIS data sets, you will see the specific tools for collecting the data at each of the relevant time points. In user manuals, you will find here the manuals that provide the guidance and support you as you collect data using each of the data set tools that were in the previous section. In the training section, you're going to find information that will be of great assistance to you. It is going to take some time to train your staff, and you need to access all of these different parts of the website in order to get the materials you're going to need to work with your staff. Lastly, the box in the lower right gives you the data submission deadlines to be sure that you are submitting your quality episodes in a timely fashion. This graphic is giving you some information about what you will find and how it is laid out. On the Home Health Quality Reporting Program page, you're going to find, as I said, the OASIS data sets and the actual link. While this is not a hyperlink that is live, you can cut and paste this and it will take you directly to the OASIS data sets themselves. On the bottom half, it identifies the location of the user manuals. And again, while not a live link, you can cut and paste this into your browser to take you directly to the user manuals. The data sets gives you the downloads with the current OASIS-D item sets effective January 1st, 2019, and the guidance manual for OASIS-D will be found there. And you will find here the Appendix C and G for the guidance manual as well. Let's look at the OASIS Educational Coordinators. This is a valuable resource. Each and every state has a designated OASIS Educational Coordinator who is responsible for ensuring that all home care providers in that state have access to these three pieces of information. First and foremost, training in the OASIS dataset administration for assessing your patients. They're also responsible for providing training and technical support in integrating the OASIS elements into your record-keeping system, because the OASIS assessment tool must be fully integrated into your assessment of the whole patient. Lastly, the education coordinator can provide technical support to you and your staff, answering questions on the clinical aspects of the OASIS tool. So how would you find your OASIS Education Coordinator in your state? By cutting and pasting the link below into your browser, this will take you to a state-by-state listing with contact information for your designated OASIS Education Coordinator. This graphic is going to show you the help desks. If you require information or you have questions related to the home health quality measures, you're going to use the Home Health Quality Help Desk. For conditions of participation related questions, you're going to go to the Home Health Agency Survey Protocols mailbox. If you have questions about the prospective payment system and policy questions about your payments, go to the Home Health Policy mailbox. Each of these three resources has a link that you can cut and paste into your browser that will take you directly there. This is my favorite, I have to tell you, the Technical Help Desk. I've spent a lot of time talking to these people because as computer people go, I'm not terribly apt. However, if you need assistance accessing your CASPER, the Data Submission and Certification Survey Provider Enhancement Reports, what we all fondly know as CASPER, the Quality Improvement and Evaluation System, KEYS, or the Technical Support Help Desk, QTSO, there are three routes that you can follow. You can pick up the phone and dial that 1-800 number. You can use the email and put in help@qtso.com, or you can go to the website. I would caution you, please remember to always keep HIPAA in mind. There's a disclaimer on the next slide that reminds you what identifiable patient information is. You cannot send anything through a contact email that includes medical record numbers, dates of birth, service dates, or anything that might be considered a patient identifier or PHI. Anytime that CMS is looking at proposing a rule change or issuing a final rule, these are published in the Federal Register and are typically released each year in July and November. There is a link on this page that you can cut and paste into your browser so that you can locate proposed and final rules that are posted here. It's important to us that you are connected to all the resources you could possibly use. The Medicare Learning Network is one such resource. On this site, you will find educational materials for healthcare professionals that are free and that can be used to educate your staff on CMS programs, policies, and initiatives. You can subscribe to the Medicare Learning Network Connect's weekly email newsletter for right up to the minute information. I would recommend that you make these an icon on your desktop so that you can always find right at your fingertips the pieces of information that you need. The open door forums are another invaluable resource. There are open door forums for home health, hospice, and DME. These address the concerns of all three of these unique healthcare areas. Issues related to home health PPS, competitive bidding for DME, and the Medicare hospice benefit itself are all topics that the forum has covered. If you cut and paste this link on this slide, you can access information from previous open door forums. You can also subscribe to the email newsletter that is related to this, and you'll find excellent information here. Now let's move on to some OASIS-D training opportunities. Here on this slide, I want to call your attention to last week's webinar on OASIS-D. Shortly, the presentation and the recording will be posted on the CMS website for you to access and use. Today's program, the Introduction to OASIS-D, Section GG, will also ultimately be posted, and a recording will be posted on the CMS website for you to use. We anticipate that in October or November of 2018, there will be a Q&A teleconference. Remember the previous slide with the spotlight and announcements? Make sure you go there so that you will know exactly when that teleconference is going to be held so that you can sign up and register. And lastly, there will be an in-person home health provider training in Baltimore, Maryland. It is being scheduled for an anticipated date in late October or early November, and a webcast will be available. So again, back to the spotlight and announcements so that you can be sure to get registered as soon as possible. We're down to the last slide. Training information and updates, as I have said repeatedly, go to Spotlight and Announcements. Cut and paste this link into your browser, go directly there, and you'll know when last week's webinar, today's webinar, are going to be up and posted on the site, and you'll know when you can register for the Q&A teleconference and the in-person training, so that you can use these two sites to get that information and always be ready. I want to thank you all for attending today and for your patience as we worked our way through all of this material. The questions that you submitted during today's webinar, as I said, will be addressed at an upcoming teleconference scheduled for October or November of 2018 and at our in-person training scheduled for later this fall. And at this point, I'm going to turn this over to Sharon.
Thank you, Kathy. So before we wrap up today's event, I just want to thank Kathy and Charlotte for their valuable knowledge shared during today's webinar. And just as a reminder, I just want to let you know as well that the full version of slides, including the answers to the polling, as well as a recorded version of this webinar, will be posted. We will send an email notifying you when and where those items have been posted. This concludes the introduction to OASIS Section GG webinar. Thank you all so much for attending and enjoy the rest of your day. Thank you.